Good afternoon and welcome to today's webinar. The title of our webinar is Measure What Matters, Advancing Multidisciplinary Care Coordination in Primary and Subspecialty Care Settings. This is part 2 of a 2-part webinar series. My name is Michelle Esquivel. I'm the Director of the National Center for Medical Home Implementation at the American Academy of Pediatrics, and I also oversee the work that occurs through our Division of Children with Special Needs here at AAP. The goal of our National Center for Medical Home Implementation is to ensure that all children and youth, particularly those with special healthcare needs, have access to a medical home. As I mentioned, this webinar is the second and final webinar in a 2-part series focusing on measuring care coordination. The webinar is brought to you in partnership with the National Center for Care Coordination Technical Assistance, and it's supported through a cooperative agreement between the American Academy of Pediatrics and the Maternal and Child Health Bureau of the Health Resources and Services Administration. Before I introduce my co-moderator today, I'd like to inform you of some housekeeping items. The slides will appear in the central window of your screen and will advance automatically. All webinar participants except for faculty are muted. Audio will be streaming through your device, and there's no call-in number. We encourage you to ask questions throughout the presentation using the question box window on the left-hand side of the screen. These questions will be answered at the end of the full presentation. If we do not have time to answer your questions during the webinar, we'll send you an answer directly via email at a later time. The webinar will be recorded and archived on the National Center for Medical Home Implementation website in about 1 week after today. After the webinar, we'll be sending out an email with a link in it for the webinar evaluation. We strongly encourage you to complete the evaluation. It will help us to continue to improve our educational offerings and also focus in on the content and topics for presentations that are of the most interest to our audience. Today's presenters have no financial or conflict of interest disclosures to announce. And now I'll move on to introducing my co-moderator and friend, Rich Antonelli. Dr. Antonelli is the Medical Director of Integrated Care at Boston Children's Hospital and is on faculty at Harvard Medical School. He has published outcome and cost data of care coordination services for children and youth with special health care needs and their families. He's consulted on care coordination and integration methodologies and measures to multiple states and U.S. federal agencies. Dr. Antonelli directs the National Center for Care Coordination Technical Assistance with funding from the United States Maternal and Child Health Bureau in partnership with the National Center for Medical Home Implementation here at the AAP. So Rich, I'm going to go ahead and turn it over to you.
Thanks, Michelle, and I want to welcome everybody. It's been a very exciting 2 weeks with the number of folks that have registered for this event. I'm so excited that care coordination is getting its time, so to speak, in the spotlight. But the reason is it's not because we're chasing windmills. It's because people all around the country in pediatric health and in adult care say, what is it, how do I do it, how do I measure it? And so we're going to continue the theme that we started with last week, talking about integration as a team sport and how it looks and feels in different settings today. And we've got 2 really, really exciting presentations today with outcomes attached. But before we move into our presenters today, I want to bring back my co-faculty member, Hannah Rosenberg, who manages the National Center for Care Coordination Technical Assistance and is a project manager here in the Integrated Care Program at Boston Children's Hospital. She focuses on research and quality improvement, work specific to pediatric integrated care coordination. So I'm going to hand it over to Hannah, and I'll be back with you guys in 2 minutes.
Great, thank you so much, and thank you to everyone again for joining us this week, and for those of you who are just joining us for the first time. Next slide, please. Our learning objectives today are the same as last week. We are going to introduce and discuss a tool intended to track and quantify care coordination activities and outcomes. and we will demonstrate the impact of care coordination in diverse settings, including pediatric subspecialty and primary care. So today we are going to be continuing what we began last Thursday in introducing two new speakers to talk about their experiences in implementing models that involve care coordination and then measuring and capturing the value of those activities and outcomes. In the webinar last week, I did speak about the care coordination measurement tool and spent some time framing it for the audience. I'll do a brief introduction to the tool, but for those of you who were not able to join us last week and who don't have familiarity with the tool, we do recommend you go back and review webinar 1 and or you reach out directly to our center. Next slide, please. So our center, the National Center for Care Coordination Technical Assistance, is in partnership with National Center for Medical Home Implementation, and our mission is to support the promotion, implementation, and evaluation of care coordination activities and measures in child health across the U.S. We are a technical assistance center, and we're funded to provide introductory level technical assistance to any entity that is focused on care coordination, capacity building, and measurement, and who's interested in using one of the tools in our toolkit to implement in their own setting. And one of those tools is the care coordination measurement tool. So if you are interested in learning more about the tool, thinking through how you can actually implement the tool or elements of the tool in your own setting, please do reach out directly to us. We have a small team, but we are, again, very willing to have one-on-one conversations with any of you after this call to talk through implementation in your own setting. We also have additional resources and services, and you can find more about those on our website, and that's included in this slide. Next slide, please. So the care coordination measurement tool that we'll be talking about today, the intention is to capture the value of care coordination. As we all on the call know, care coordination is a critical component of high quality and safe healthcare delivery. However, many of the activities of care coordination are very rarely tracked, and often they're not reimbursed. So the CCMT, the Care Coordination Measurement Tool, allows its users to actually collect data on the care coordination activities, on the resources needed to provide and perform those care coordination activities, and then links those to outcomes that occur and are prevented for patient populations. So positive outcomes that occur because care coordination is successfully provided, and negative outcomes or adverse outcomes that are prevented due to the effective delivery of care coordination. So ultimately what the tool does is inform quality improvement and financing mechanisms. Again, we did expand on this last week, so if you're unfamiliar with this content, we're happy to connect after the call. Next slide, please. This is the Care Coordination Measurement Tool template. So this is the template that we provide all users when they're thinking through how to best implement these measures in their settings. The tool is intended to be adapted to reflect activities and outcomes in diverse settings. We have groups across the country that are sitting in very different types of healthcare service delivery. So some of our partners that implement the tool aren't in the medical space at all, but are in the community or school-based settings. Again, the tool is best used when it is tailored, and our center can provide one-on-one assistance to your group to think through how you might best tailor it in your setting. We will now be hearing from two individuals who led the adaptation and implementation of this tool in their setting, and then the next steps that they actually use the data to inform work in their space. So I'll turn it back over to Richard Antonelli, who will introduce our first speaker.
Thanks, Hannah. And it is absolutely a privilege to introduce a colleague, Lori Hardigan, a nurse in the Division of Gastroenterology, Boston Children's Hospital. She's going to discuss how her team measured the value of care coordination efforts for children with gastric feeding tubes, which is a marker of patient complexity. And I'm going to pause for 1 second and just point this out to people. When you look at care coordination from the adult side, it's often very much linked to specific disease entities. One of the key takeaways of the messaging that Lori is about to deliver to you is we use G-tube dependence as a marker of complexity, specifically not a singular diagnosis, which for those of you on the call, if you've got a background in pediatric chronic conditions, you know that we don't have half a dozen chronic conditions. We have hundreds of chronic conditions. So you're going to listen to Lori's presentation through the lens of complexity writ large. With no further ado, my friend, colleague, and fellow researcher, Lori, thanks for joining us today.
Thank you, Rich. Good afternoon, everyone. I'm thrilled to be able to present our experience in using the CCMT to help quantify the work the Boston Children's Hospital GI nurses do in managing complex pediatric patients with a variety of enteral feeding tubes. I'm Lori Parker Hartigan. As Rich said, I've been a pediatric nurse for over 30 years and have worked in GI for most of those years. Next slide. First off, I would like to give you a little snapshot of what our GI practice at Boston Children's Hospital looks like. We have over 60 providers, including attending gastroenterologists, GI fellows, and nurse practitioners. We see approximately 60,000 outpatient visits per year on our main campus and 12 satellite locations. Along with our surgical colleagues, we partner to place about 350 enteral feeding tubes yearly. That would reflect G tubes and GJ tubes. And we also send countless children home with nasogastric tubes and nasal jejunal tubes in place. On our inpatient side, at any given point in time, we have at least 40% of patients have some sort of enteral tube in place. Just gives you an idea of what the scope of complexity of the patients we care for looks like. In terms of nursing support, in our ambulatory GI practice, we have 3 registered nurses, and we partner and work closely with our physician and nurse practitioner colleagues to do care coordination for our complex children. Next slide. How do we at Boston Children's Hospital GI successfully implement and sustain a model of care for complex medical patients? I think there's 3 things I want to focus on. First off, we have very experienced nursing staff that can lead to optimal outcomes. My nursing staff has experience from 8 to over 40 years of pediatric nursing experience, and their work reflects a depth and breadth of knowledge that I think may be unequaled. I am a little biased. Secondarily, our team, physicians and nurses, are committed to patient access for urgent appointments for both providers and nurse visits. And finally, we've worked hard to strengthen community supports for management of our patients, especially those who live far from us. We partner closely with our primary care and medical home peers. We work closely with them to increase their comfort in managing complex patients. We work diligently with our VNA, our school nurse colleagues, who really are our eyes and ears in the community and the home, so we know what's going on with our kids. And we really rely upon home medical supply companies who are very skilled at working with patients and families with complex needs, providing them with necessary supplies such as enteral feeding tubes, feeding supplies, and special formulas. In addition, they're very skilled at working with payers so that we can be sure our patients' supplies are covered by their insurance. Next slide. How do we deliver coordinated care to our patients with enteral tubes? The nursing staff, in addition to seeing patients in the clinic itself and in the office setting, spend many hours conducting family-initiated telephone triage for GI patients, including many of children with enteral feeding tubes. And as Rich commented, for this project, we're using the feeding tube as a marker of patient complexity. I want to emphasize that this approach has been a reactive care coordination model, so families are calling us with their concerns. As we began this project, our goal was to determine if and how these telephone encounters met the needs of the family and led to desired outcomes. Also, again, as a manager, I wanted to truly see what was the unseen care that we were delivering to our patients by nurses in between office visits that were keeping these kids home and safe. Implementing the Care Coordination Measurement Tool, or CCMT, allowed us to track activities and outcomes. So what did we do? Next slide, please. Using the CCMT, the nurses collected data for 4 weeks total, 1 week a month for 4 months, and we were able to collect data on 216 telephone encounters. We asked the nurses to collect as many data on as many encounters as possible without interfering with their workflow. We found that the CCMT provided an easy way to document care coordination activities and outcomes. And I just want to emphasize, anything we did in this realm had to be easy. We had to sell the use of the tool to the staff so that we weren't adding too much more to the nursing workload, which was also already substantial. Fortunately, we could create an electronic version of the CCMT using the REDCap program for data capture, and we were able to embed a link to that tool within the electronic medical record. So during the call, the nurses could easily click between the patient chart and the tools to document the care delivered in real time. Next slide. The key outcomes we looked at included length of call, was RN level of competence required, why were families calling, did anything else happen during the call, and what did we prevent? So 2 key take-homes are reflected on this slide. First, and I think I was even surprised by this, 73% of the time our calls took 10 minutes or less to achieve a resolution. And I think the take-home message here is that experienced GI nurses are able to deliver care efficiently with the patient need being resolved during 1 phone call, maybe 2. 97% of all encounters were recorded required a registered nurse level of competence. And this tells us that these calls were appropriately allocated to the nursing team. What that does is it frees up our administrative colleagues and physician colleagues to do work that is more appropriate for them. Next slide, please. So this graph shows why families called, the primary reason for the call. And as you'll see from the slide, 66% of the time, the initial reason for call was focused on clinical management. This might be a skin problem, infection, bleeding, a dislodged feeding tube, fever, feeding intolerance, nausea, diarrhea. 47% of the time, families called needing help getting prescriptions, supplies, or other services. In that situation, we were able to identify gaps in services that could lead to a poor outcome, children running out of formula, running out of medications, and that sort of thing. And 20% of the time, patient and family education was provided, parents calling to clarify care or understand how to better care for their child. Next slide. I think I need to go to the next slide after that. Thank you. During the call, we also uncovered other care needs. And as you can see from this slide, often the triage calls would result in uncovering additional unmet needs. Most often, again, a clinical management call, but also patient education. And for me, this really reinforces the idea that I think is central to nursing care, that nurses are really geared toward making every patient encounter an opportunity for learning. We were able to identify and address needs in the same call, preventing adverse outcomes of unmet needs going unnoticed. Next slide, and I think next slide. Through care coordination, we were able to prevent some quote-unquote unfavorable outcomes. And as you can see from the graph, there were a number. I think most importantly that the ability to triage urgent issues to an appropriate level of care was really important. As you see, 19% of the time we were able to prevent a visit to the emergency room. Other preventative visits were urgent clinic visits or specialist visits, as well as medication errors. I did want to give just a quick example of how we would prevent an ER visit. A common reason for families calling is their enteral tube was dislodged and they were unable to replace it at home. Typically, they would travel to the emergency room to have that placed. If they were talking with one of the nurses, we could either coach them through placing that tube at home or set up an urgent RN visit for them to have that replaced fairly immediately, thereby avoiding the emergency room, and I think also avoiding a lot of trauma for the children. I think that care coordination through this graph led to us having improved outcomes and reduced cost. And in terms of safety, we were able to provide more timely responses to patient problems and often can shift problems to more appropriate level of care. We were able to meet the patient need quickly and efficiently. And I might add that many of these visits, I believe, in other settings might have been shifted to a physician visit, but because of the strength of our team, we could shift it to a registered nurse visit, which is a lower cost visit, thus freeing up the physician to see our more complex patients. Next slide. So what did we learn? Conclusions. By using the CCMT, we validated the work GI nurses do to deliver care to complex patients with feeding tubes. When we presented this data to our staff, their morale soared. They really felt like we knew what they do. And that led into creating a culture of willingness and flexibility among the team to really continue to do the work that needed to be done. It also showed us we needed more RN visit availability for urgent enteral tube care appointments. So we set up more visits in our Boston and one satellite location. This then supported diverting patients from our emergency room. Our work with the CCMT really laid the groundwork for us about shifting care from high-cost settings to the clinic or telephone, and really has set the stage for success as we start to think now about prospective, proactive care management within our new ACO model with MassHealth. Our work has also been foundational for using the tool for other clinics within the Children's Hospital system, including the Home PN program, our infusion center, spina bifida program, and our Center for Inflammatory Bowel Disease. Next slide, please. So next steps. I think we know we want to shift to a more proactive care coordination model. So we have two ideas that we're starting. First, we're going to be using the Boston Children's Hospital Simulation Lab to better train our families to replace nasogastric tubes at home. Many of our young infants go home with NG tubes, and parents are afraid or uncomfortable to replace these tubes, and they're also wary of practicing on their children because it's painful. To use a mannequin and to get them confident in a simulation setting, we think will make a big difference. The second thing that we're piloting now we're looking at using a telemedicine visit in substitution for the 1-week post-op check after initial enteral tube placement. This will be done 72 hours post-discharge and will be on a telemedicine platform and will be managed either by a registered nurse or nurse practitioner. Next slide, please. The final slide just shows several publications that have come out from my Boston Children's colleagues. So I just want to give a shout out to my peers in cardiology, the Patient Liaison Center, and neuroscience for the strong work that they've done. Thank you for listening, and I look forward to taking your questions after Dr. Yogman. Thank you so much.
That was wonderful, Lori. Thank you so much. We're going to pivot now to a presentation from Dr. Michael Yogman. Michael is a real practicing community-based primary care pediatrician at Yogman Pediatrics, an assistant clinical professor of pediatrics at Harvard Medical School. He's a fellow at American Academy of Pediatrics. Of note, Michael has significant leadership responsibilities as the chairperson of the AAP's Committee on Psychosocial Aspects of Child and Family Health. I'm really thrilled to be able to share Michael's work with this group because he's done a lot in the space around social determinant, children at risk, behavioral health, educational needs. And this is really for those of us that have been working for decades and decades to re-engineer care into that medical home model. What you're about to see is really how that looks and feels in practice. He'll be focusing on how he's been able to capture the value stream of care coordination to support his evolving model. So with that, Michael, I'd like to hand this over to you.
Thank you so much, Rich, and Lori, thank you so much for your elegant presentation. I want to start off by emphasizing that we entered this space to really address the urgent needs that children had for mental health care, for behavioral health care. And as we developed a quality improvement project with a integrated licensed clinical social worker, we quickly realized that efficient use of her time around behavioral health required a different model of care coordination for behavioral health. So that's really how we entered this space. So let's go to the next slide, and I'll tell you a little bit about our practice. It's a small private practice committed to the whole child and meeting the emotional, developmental, and educational issues in addition to their medical care and illness care. We're a patient-centered medical home and have a care coordination team that includes a licensed clinical social worker and a parent partner who had lived experience who helped us for a period of time. Modifying the care coordination really developed for children with complex special health care needs to the behavioral health needs, which involved a multiple of coordinating with other providers, schools, and other resource teams. So let's start by focusing on the challenges that we faced. If we can go to the next slide. We're all aware of the challenges families face in accessing behavioral health care. Stigma, lack of trained providers, particularly in early childhood, long wait times, and insufficient insurance payment for behavioral health services. The next slide. As you can see, lots of data here that only 20 to 25% of affected children with a mental health diagnosis actually receive treatment. The lack of treatment has a long-term effect on children with chronic mental illness at older ages. Many who do receive care are not receiving evidence-based care from a trained provider, and yet only 30% of practicing pediatricians feel comfortable managing or co-managing any mental health condition other than ADHD. So the exit model is referral to outside behavioral health providers, lots of gaps with follow-through based on long wait times, lack of insurance coverage, and the problem of a referral to somebody who a parent doesn't know. So what we did, if we go to the next slide, developed a quality improvement project, grant-funded, from the Harvard Pilgrim Foundation that utilizes a co-located behavioral health and care coordination integration model in our office. And fortunately, we had some assistance from the grant with a data manager so that we could, at the same time, start collecting some data on the triple aim, on both patient and provider experience, on population health quality, and on cost, based on what we could get from our contracting organization about claims data. So back to behavioral health needs in primary care on the next slide. We know that behavioral health concerns are now among the top 5 reasons for pediatric office visits, as we've managed better control of infectious disease thanks to immunizations. And I think our office visits are now largely based around chronic illness and behavioral health. 20% of children have a mental health diagnosis, and the effort of our quality improvement project was to see if we could better serve those children. So we hired a licensed independent clinical social worker, starting out with her doing both treatment and care coordination, but rapidly added a parent partner as a care coordinator to work under the supervision of the LICSW. The LICSW could provide consultation to pediatricians, assessment of children that maybe were referred on the spot for what we call the warm handoff, which is a crucial part of this model, so that if a pediatrician is seeing a child for whatever reason, whether a health maintenance visit or an illness visit, identified a behavioral health concern or based on a positive screen, could walk that child across the hall, and the social worker had the availability often to meet with that, to at least meet the child and parent in person, beginning a relationship, or to even actually see them. And I think the advantage of that kind of warm handoff is the week spent of a normal therapist developing a therapeutic alliance could be short-tracked when the relationship the pediatrician had with the family could immediately be transferred to the social worker, and the history could be conveyed in a relatively efficient manner. So in order to protect the social worker's time, she was able to provide short-term treatment, care coordination, but for children with relatively more intense or severe behavioral health disorders who might need long-term treatment, there we used care coordination to manage a referral to preferred providers that we had a relationship with in the community. Our metrics to look at the outcome were measures of patient experience, provider experience, population health quality based on registries that we're able to track in our electronic record, and of course the cost measures that I referred to earlier. So the next slide shows how we modified Rich's CCMT tool around behavioral health, particularly to look at what the behavioral health needs were, whether the focus of the encounter was treatment, was developmental or behavioral, whether it was educational, whether it was referral management, whether it involved community agencies, or whether it involved legal or judicial interventions. While there's some overlap with the CCMT, we modified this to really focus in on behavioral health. And our outcomes, particularly that we'll come back to, although we don't have the kind of data yet that Lori presented, but we have some indication that we certainly were preventing ER visits and hospitalizations, and you'll see that reflected in our cost-saving data. So the next slide shows that this was a 3-year project from 2013 to 2016, and over that period of time, the social worker provided services to 366 patients, over 1,500 services, including both phone encounters and in-person visits. And this shows the breakdown of the children in the various registries that we tracked and identified over time. So there were 123 children who were seen in our ADHD, and you can see each of the groups one of the most important groups was the complex special health care needs comorbidity children with behavioral health. If we see the next slide, I want to move quickly through the data. The measures were the Parenting Stress Index improved, the Family-Centered Care Assessment, the Client Satisfaction Questionnaire. The provider experience, I think, was very important in terms of improving the culture of the practice. Physicians believed that their work improved, and we used something called the Organizational Social Context Scale, which showed dramatic improvement. Next slide. The improved outcomes for our children in the registry with ADHD using the Vanderbilt, improved outcomes for the patients with complex special health care needs using the pediatric symptom checklist, less improvement for children with serious emotional disturbances. It had to do with the timing of our measures using the PHQ-9 and when they're identified in the midst of a crisis. Next slide. Want to finish up here. I won't go through the details of this data since I summarized it on the previous slide, but I want to just get to the cost outcome data, and then we can provide our conclusions. The next slide. So this is the total medical expenditures from claims data for the subset of patients who were continuously enrolled from 2013 to 2015, and particularly for the children with complex special health care needs and comorbid behavioral health concerns. We showed some pretty dramatic, there was a small number, 19 kids, dramatic change in cost over that 2-year period, and the average overall of the total population showed some improvements in cost. The next slide just looks at the total group of patients, not those continuously enrolled, but overall, over that period of time, again, similar improvements in cost in the average overall group, and especially the children with complex special health care needs and comorbid behavioral health concerns. So the next slide, I think, just is the paper that we published if people want more details. And I think the last slide just gives some of the references. So our conclusion was that the practice was completely transformed by having an in-house licensed clinical social worker. The challenges have to do with sustainability going forward and once the grant goes away. So let me stop there and welcome questions.
Thank you so much, Dr. Yagman. That was an excellent presentation, and both presentations were wonderful today. Before we do take questions from our audience, I'd like to draw your attention to a few resources that may be of interest to you. Each resource listed on this slide that's on the screen right now is hyperlinked, and the slide deck will be sent to all webinar registrants after the webinar so you can easily access each resource. Additionally, if you would like to contact the National Center for Care Coordination Technical Assistance or the National Center for Medical Home Implementation, our contact information is included on this slide. We do have a few minutes for questions from our audience. So as a reminder, please submit your questions through the chat box. And I believe that we have a few that have come through. So my colleague Alex Kuznetsov is going to summarize some of the questions into themes and pose them to our speakers today.
Great, thank you, Michelle. So the first question is for Dr. Antonelli and Hannah Rosenberg, and the question is, can the care coordination measurement tool be used for adult populations?
Yes, the answer is that this care coordination measurement tool is designed to be adapted. Adults, children as well. We have demonstration projects in surgical specialties, medical specialties. We're branching out now into community-based organizations where people, vulnerable populations need social support and everything from connection to housing security to food security. So it is designed to be adaptable because care coordination crosses settings and crosses disciplines.
Great, thank you. So the next question is probably probably all the faculty can weigh in on this. So the question is if the faculty can provide some more details on how to identify or document when an outcome has been prevented as a result of care coordination.
So this is Hannah Rosenberg, and I can provide a broad response and then invite the other speakers to give examples as well. So what we generally say is for people who are using the care coordination measurement tool to track activities, what we ask them to consider is if they had not provided that care coordination, what would have happened and what potentially wouldn't have happened. So what wouldn't have happened is what we ask them to track in the outcomes. So we say, or outcomes occurred. So we say if you are providing education on the phone or doing medication refill or adjustment to medication or connecting to a community service agency, what is basically that next step? So why are you doing that? And that's really how we get them to think through what outcomes they're including in the occurred and prevented columns. For prevented specifically, some of the suggestions that we basically have outlined in the template that I think some of our speakers use as well are ER visits. So as Lori spoke about, being able to provide that guidance, clinical guidance over the phone or pulling them in for an urgent clinic visit as opposed to referring them to the ER. Another example is preventing a safety issue because you're able to do a medication discrepancy reconciliation over the phone. We can also, that's kind of a general example, but we can also talk through individually with groups kind of one-on-one in terms of what their general body of activities are and what we would recommend for outcomes. And then I'll open it up to anyone else.
Yeah, this is Dr. Yogman. I have three anecdotal examples that I think are very telling. One is prior to integrated behavioral health, if a school nurse or a family called that their adolescent was suicidal, we would almost universally immediately refer that child to an emergency setting. Now, we have the capacity and have avoided ER visits by having the patient come right over, meet with our integrated behavioral health provider or social worker, and usually has been able to contract for safety and avoid that ER visit. That's the first example. The second example is a parent of a preschool child who is having quite disruptive behavior in a child care setting. And the intervention of our social worker was able to work with the child care setting and prevent expulsion of that child from the preschool by providing both some management techniques for the child care provider and for the parent, and to begin to address the behavioral concerns in the parent. The third example, which I think is most telling and most easily implemented, is with screening for postpartum depression. Identifying, using the Edinburgh, identifying a depressed, and in this case a suicidal mother, at the 4-month visit and 2-month visit, enabled us, with the assistance of the social worker, to immediately arrange a safe emergency room evaluation of that mother, her hospitalization, avoiding her fears of harm to her infant, such that even without medication, with therapy, she was discharged from the hospital, and at the 1-year visit, the birthday card from the parent said that you really saved our lives. So I think that the kind of access to behavioral health in a primary office is has all kinds of ways of avoiding more costly outcomes.
Hi, this is Lori. I just briefly, we sort of struggled with this with our team. we all sat down and talked about situations where the patient might end up in the emergency room, and then we identified sort of using kind of an approach of inter-rater reliability. Is this a child who would have ended up in the ER if we'd not intervened, or was it not? So that's sort of how we characterized and looked at it through that lens by sort of using the team approach based on our experience of, doing GI telephone triage for, 20 years. We sort of know how patients behave. So I think that was helpful.
Thank you so much to both of you for your answers to those questions, and to all of our faculty today for your presentations and for your active participation. We appreciate your time. We appreciate that you've shared some very practical and real-world experiences, and also your expertise in terms of using the CCMT to measure care coordination. As mentioned earlier, the webinar recording slides and any unanswered questions will be archived approximately a week from today on the National Center for Medical Home Implementation website. And then shortly after this webinar, you'll receive a link to an evaluation survey. We really strongly encourage you to respond to the survey. It should only take a couple of minutes. So again, we can continue to improve the quality of our webinars in the future, and also learn more from you about what content you're interested in. Thank you so much to everyone for your participation today, and have a wonderful afternoon.